Vision Pro is very interesting device that I think, but some patients need more aggressive procedures, such as as you told me, the intermediate patients who want surgery and those who want very non-invasive treatments. Then, what about the role of ultrapulse in those patients? What do you think about it?
Guys, ultrapulse is my baby. Don't touch it. It's the best device ever produced by a company in the world. My nurses in my office, they know that I'm calling ultrapulse as my baby, so don't touch it. It's very dangerous to arrive at 1 meter distance. So no, I'm joking. You know, ultrapulse is an unbelievable device for cosmetic purposes. You can do a very soft procedure if a patient has a theater in a couple of days, or you can do a very aggressive full face resurfacing with tightening effect, with a strong collagen production. But naturally you have to put on the plate, on the table, that patient has to pass a downtime period that varies from few days to 10 days max. So you have to discuss with patients regarding this downtime and naturally the results. No pain, no gain. If you want to achieve a very good results, you must be aggressive. But the ultrapulse is the best device to treat other conditions, not only cosmetic. When you have severe scars, it is the device that is allowing you to go so deep inside the skin and maybe doing the drug delivery. So adding some drugs on the top that can penetrate inside the hole created by the device. And I'm using drug on pathological scars, but you can think that you can use that with PLLA, for example, or you can use it with hyaluronic acid if you want, and so on. So at the moment, what I'm thinking is that the ultrapulse is the real #1 of the CO2 on the market, and it will be in the future, because the technology that there is behind is at the moment the #1, and now with some new features, so we can go very deep inside the skin. We can work very superficially. We can combine these two things. We can do a medium procedure. So it depends on what we want to achieve, and naturally accordingly with the patients where we want to arrive and which kind of results we want to achieve.
Yes, ultrapulse is very good device. I totally agree with your words, but it's very hard because it's like unexpectable sometimes. So as of scar, when I give them with deep FX scanner and did procedures for my patients, and after several days I expect that all the discharges go away, and I wish that I can see the better lesions, but sometimes the scar widened and sometimes worse. So it's very hard to expect the results. Then how can you control your treatments for when you do ultrapulse?
On scars or for cosmetic purposes? On scars?
Yes, scars.
Okay, on scars, in a practical point of view, I'm suggesting to use some magnification lenses. And you think, okay, where I want to go? I want to arrive at the 50% of the thickness of that scar. And I'm thinking that to arrive there, I need 30 millijoule, for example, okay? Well, you hit one shot at 30 millijoule, but look with the magnification lenses what is happening to the skin. The interaction between the energy and the skin is the answer. The answer is look at the scan. If you see a contraction, this is not good. You have to reduce the energy.
Oh, really?
Because we have to relax the scar. No, we have to have a collagen remodeling. We have not to contract that. The opposite is the cosmetic. Okay. So this is important. Looking at the scar, thinking about the thickness, again, deciding where I want to go, and therefore where as thickness means energy.
Yeah.
Decided the energy, I can decide the density. And the general very important rule is higher the energy, lower must be the density. Okay? Yeah. And then this is my idea, this is my plan, and this is my plan on that patient, on that scar. And so I hit one shot and I say, okay, no contraction, I can go ahead. Maybe moving, you arrive in a place of a scar where that scar is thinner, and you hit a shot and you start to see the contraction. Stop, reduce the energy, and go ahead. Or if we want to see the other side of the coin is start slowly, increase gently the energy shot by shot till you start to see contraction, and then you find the right settings. Okay, so it depends. The second thing is to take care as the anatomical region. If you are treating a back of a man that is 1 centimeter thick, the dermis, or if you are treating the eyelid on the neck, is a completely different thickness of the skin. And therefore, this is to take in consideration when you are doing procedures, because we cannot think, okay, I'm using 120 millijoule to arrive at that depth in the neck, because or you have a very thick scar over there, or you're doing a mistake. So I think where I want to go inside that scar, that means the energy. Considering the energy, I can decide the density, and I'm not sure I did the right job. So look at the scan and look at the interaction between energy and skin. If you see contraction, this is too much, and reduce it. Oh, and doing this, it's very difficult to teach, because it's very difficult to, if you increase a lot the energy, you can see a great contraction. But that's why I'm using magnification lenses. So to start to see that, stop it and reduce just a little. So it's like having a threshold. Okay, we have a threshold. We have arrived to the threshold and staying just a bit lower than that point.
Yeah, that's very hard points there. So for every doctors who use this ultrafirst, because that's the very trivial, right?
But I think that this is the right approach with all devices. It's not because now I decided to use these settings, I can use all these settings on the old area. I have to change the settings. For example, a face. Okay, a face which is the thickest area of the face. Speaking about skin, is the nose and the chin. Okay, and excluding the eyelids that we know they are very thin. The thinner is the forehead, but the thickness of the skin is so different that I have not to use the same energy, the same settings on two different anatomical regions if we want to achieve the same results. I'm speaking. So is knowing the anatomy, and this is very easy, reduced by 10% if you go to the forehead, for example, or reducing the density if you're working on the forehead instead of the energy. So it depends. But is knowing anatomy is not very easy. It's not very difficult for me.
Yeah, just people you go on your procedures that you try to test patients first, right?
Yeah, but that is good. That is also for medical legal reasons very important to do. So do 1 or 2 shots of test. That is okay. The problem is that if you are testing the skin here, maybe if you're doing that procedure here is not the right thing because the skin is not the same.
All right.
So I think this is more for medical legal reasons, the test on the skin. And therefore, I think that experience can play a very important role. If I have to decide, I will be always extremely safe, and it's much better to do a second procedure, maybe increasing just a little the settings I used during the first one, instead of going too high during the first one. So this is my approach.
As a ultrapulse, the company, they provide the data, the energy and depths, so we can presume depths we can apply at patients, and we know the some not exact, but we expect the depths of the skin, as you told me, according to the area of the basal skin. So we can just give them a small test before the procedure, right?
Yeah, means they have to. In the new version, you will see that applying some energy on the screen, you will be able to see the depth of the ablation. Because for many doctors, it's much easier to speak about microns of ablation instead of millijoules or joules. But we are not computer, okay? Right. We have a mind, and we have to use a critical mind, and we have to use our critical mind and what we see on that patient. Because, for example, there's another element that no one is taking care, that is very important on the results, is the amount of water inside the skin. If that patient applied for months a lot of moisturizer on the skin, has a very hydrated skin, we have a lot of water inside the skin, and the CO2 is not penetrating too much because it's finding a lot of targets on the surface. On the opposite side, if you have a very dry skin, that's why I'm not injecting patients for at least months before doing fractional surgery. If you have a very dry skin, same patient, same thickness, but you have a dry skin, you go deeper. So that is very important as well to understand, and therefore, again, what I'm thinking is look at the interaction between energy and skin in that moment.
Yeah, that's quite important, right?
So we are medical doctors, so we are not computer. We have, otherwise, they say use 1, 2, 3, 4, 5, and use 1, 2, 3, 4. You have to adjust settings to different patients. I'm saying, as I told during the talk yesterday, I think, we cannot compare the skin of a 25 years old man with the skin of a 70 years old woman. No, usually the 70 years old woman has a very thin skin, and the 25 years old man has a very thick skin. His skin maybe is the cheek always, okay? But the thickness is completely different. The hydration is completely different. So we have to modify, we have to adjust a better. The right answer is we have to customize procedure on each of our patients.
Yeah, that's quite ideal procedure. The ultrapulse, the carbon dioxide laser, can be used as a drug delivery method. Do you use it as a drug delivery, one of the treatments for with ultrapulse laser?
I always use. I love my ladies knows me very well. We are creating holes inside the skin, and we know a lot regarding the heat shock proteins that we are producing. We know the inflammatory cascade we are creating. We know that we are stimulating elastin production. We know that we are inverting the ratio between collagen type 1 and type 3. So we know all of that things. But guys, what we are doing, we are creating holes. And because we have holes, and holes that arrive always at the same depth, so very uniform way, why not to use drugs on the top that can penetrate very well inside the skin and can diffuse? And the secret of ultrapulse compared to other lasers is this one. around the ablation, we have a denaturation halo, isn't it? So the denaturation of the dermis around the hole. Only with the ultrapulse, this thickness, the thickness of this halo of denaturation is very small. And therefore, because this is very small, we are sure that the drug penetrated can diffuse. If you have a huge denaturation around, except the risk of PIH and blah, and blah, and blah, but you have a very huge denaturation, we are not sure that the drug that can penetrate can diffuse to the surrounding tissues. So a controlled thermal damage, that is another very important, I think, aspect of using the ultrapulse. Has the highest ratio between the energy and the ablation and penetration inside the skin, and that's because that's coagulation halo is not so big.
Sometimes I can observe a backflow after the ultrapulse treatment. So at that time, the backflow, the blood, after applying the medication, that I don't think that the medication will penetrate into the skin because of the backflow. So any solution to enhance drug delivery when a backflow happens?
I agree with you. If you have the blood coming out, the penetration of the drugs cannot be so good as without the bleeding. But you have to consider that there's another thing, that if you do some shots, you can have some swelling, so the edema. And the edema of the surrounding tissue usually stop the bleeding. If you hit with the fractional, with the ultrapulse CO2 the skin, and you see one drop of bleeding or a couple of drop of bleeding, and you wait, this is not continuing of bleeding. Then you can remove it, and then you can apply the drug on the top. I'm not sure that channel is not full of blood, so that the penetration is good, but I'm not treating one single 120 microns diameter area. I'm treating a surface. So if I have few of these channels full of blood, I do not think that can play an important role. But on the other side, I absolutely disagree on using microneedle to do drug delivery, because with microneedle, if you pass the dermoepidermical junction, we always have bleeding in all holes we have. If you compare that, okay, excluding the heat generated by the laser, that is better, and everything. But if you are using a needle, you have bleeding. If you're using a CO2, you can have bleeding. That is another thing.
How about applying the sonic devices such as
applying, sorry?
The sonic
ultrasounds to push the drug. That could be. That's absolutely could be. I'm using a classical massage. That's I think is enough. But if you're using ultrasound, pushing something, and I fully agree, no problem.
What kind of drugs when you do drug delivery with ultrapulse laser?
On scars?
On scars.
I'm using triamcinolone, that is a steroid. Yeah. I'm using 5-FU, and I'm using botulinum toxin. And I put that all together in what we are calling a cocktail. It's not my invention, okay? It's not my mind. The ratio between 5-FU and TAC and triamcinolone can vary from 3 to 1, 3 parts of 5-FU and 1 of TAC, to 9 to 1, 9 parts of 5-FU and 1 of TAC. And playing with this difference accordingly to the feature of that scar is very important. The explanation I'm giving to my patient on why to use this is this. This is not a scientific level, okay? It's trying to be as much clear as I can. If we have 100 cells inside the scar, using the 5-FU, we can kill some of them. So from 100 cells, we can arrive to 80. We know, we do not know why, but we know that triamcinolone is saying to these 80 cells to reduce the production of fibers. Okay. And botulinum toxin was demonstrated that is able to change the proliferation ratio of the fibroblast only of pathological scars. That's very important. Means that is a botulinum toxin is going to normal skin. They do not do anything on normal skin, but on the fibroblast of a pathological scar, they are reducing the proliferation ratio. So what that means, okay, starting again, 100 cell, 5FU we kill and we arrive to 80. And we say to these 80, reduce the collagen production. That's okay. But these 80 cells, as everything in our body, start to be replicated, okay? They die and they born again, they die and they born. And with the botulinum toxin, we can reduce this proliferation ratio. So at the end, session by session, we can arrive not to 80 cells, but we can arrive to 20. The other thing is, these are the drugs usually I'm using. When we have a trophic, we can, David Ozog and Jill Weibel, they demonstrated that you can use an hyperdiluted PLLA that can penetrate inside the hole and then can stimulate new collagen production where we need. So I think that everyone can play with what they want. You know, we can consider the fractional CO2 as a drug delivery system. We are lucky that a CO2 is working by itself. It's proteins and whatever. But why not in some kind of scar? Why not to add the drugs to have a better improvement?
And have you ever done drug delivery with ultrapulse for rejuvenation, the wrinkles or
no
skin saggings?
No, I don't.
Just for pathologic scars?
On pathological scars, yes.
Today, I'd like to thank you very much for this interview, very long interview. And I wish you have a very good time in Korea.
Thank you very much for the interview. Very nice questions, very interesting questions, very tricky questions. And hope to see you soon. Next time I will come to Korea. Thank you. Ciao.
Ciao.